Hello, everyone, and welcome to the October 2021 Pre-Hospital Care Research Forum Education Research Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build the body of evidence to examine pre-hospital emergency care. Now, the PCRF promotes research literacy to advance the science of EMS educational research. So here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Corey, and I am joined by David Page and Katie O'Connor, and soon Dr. Bill Toon will join us. The study we're going to be looking at today is the current state on the use of simulation in paramedic education. This is published in the Australasian Journal of Paramedicine in 2021. So first, before we get into the study, we do have a little announcement to make, if I can forward this slide. David, would you like to actually announce this, since we've been talking so much about this? Is a very exciting thing that we've got coming up soon in about a month or so. David, do you want to describe our the annual International Paramedic Research Conference virtual?
Yeah, I'm so excited about this. I forgot to unmute myself. I'm you know, adrenaline, deer in the headlights muting syndrome. So the exciting part of this, you know, COVID may have forced us all into virtuality, but there are definitely some benefits in the virtual world, and one of them is collaboration across the ocean. So what's happened is the UK College of Paramedics is normally has a yearly conference for research dissemination for their members and for folks in the UK, and the Australasian College of Paramedicine has the same. PCRF went virtual last year and had about 300 people in attendance. So we reached a nice volume of people that normally don't attend, you know, kind of an in-person EMS World Expo has lots of providers, but not necessarily a lot of researchers and or people who are super excited about research. You know, Steve Barry steals the show, and he should, and he's great, but it's not like sexy to talk about research. So we want to make it fun and interesting, and we also want to give a platform for our authors that have submitted research to the PCRF to be able to disseminate that wide. Dr. Ginny Rinkowitz won Best Research, and her work with suicide and compassion fatigue is just groundbreaking. We need to get that out there. Mackenzie Ferguson in Orange County, California, won Best Research for some child abuse research in education, EMS education. So we think that it is really important to disseminate this. So we're coming together, all of us, Kumbaya. This world event is going to be a conference-a-thon. It's a 24-hour free conference. We're going to start at 5 a.m. Eastern Standard Time on November 30th and go all the way into December 1st, taking time zone turns, kind of the UK, it'll be about 10 a.m. in the UK, and there'll be panels, but we've had about 85 submissions of EMS research, so paramedic research, in the term of paramedic encompassing both providers that are EMTs and paramedics. And so this is a really wonderful event, and it's free. We have a partner, Prodigy, who's going to help us with the continuing education credit for CAPC long after the conference is over. And we think that the live format with Q&A with the authors is going to be very enriching. 2 different tracks. We have invited speakers, and I think it's definitely a time to invite folks to participate. So really, really excited that this group has come together and that we're really going to be able to participate. Registration is not yet open in the US. We want to capture your CAPC information so that we can give you college credit, CAPC credit. And that's what I have to say about that. So
this is so exciting. I love the whole idea of the conference-a-thon. It's a 24-hour shift for researchers. So it's awesome. Yeah. I love it.
Addictive,
love that idea. Except if you are time zone impaired, like me, that's what I love about the little countdown that's on that
Well,
site. If you go to their site, they've got a
two
little
in the
countdown
morning,
going.
Megan. You can do it. Wait,
8 a.m. Pacific, I think.
I
I don't
think
know. I'm
that
gonna have to call Dave and say,
Katie
what
O'Connor
time do we
is on
start?
this podcast,
Actually,
and she has
earlier.
a pot of coffee to keep her awake. It's
Yes.
like, Zoom to Zoom to Zoom. So, we're just gonna, get there you
There it
go.
is.
Here we go. Perfect. All right. The pot of coffee. I'm working on my PCRF mug here. So yes. All right. Sorry. We digress.
Yes. No, that's very exciting. I mean, it's like I said, a 24-hour shift for researchers. What else could we want? So, yeah, more information. You can go to prehospitalcare.org. There's information that'll be there about registration, but wait for us to get that CAPC thing going. So, research. Let's dive into some research today. This is, and don't forget, you're out there listening, you can pop into the chat, or if you have something longer to say, if you have a lot of experience with research, or if you took a browse through this article, we would definitely like to hear from you also. We'll talk a little bit of research, we'll talk a little simulation, and move on from there. It's obviously a really important topic coming up. So I put up here a couple of definitions for simulation, because this article, which is going to review, it calls it a current state of affairs, kind of the state of the simulation and pre-hospital care, specifically pre-hospital care, starts out with a definition. And that got me thinking, well, I've seen the definitions before, and there is a healthcare simulation dictionary. The second edition is published for free on either the Society for Simulation in Healthcare website. It's also on the COA EMSP has a link to it on the front page of their website. The second edition was just published in 2020. American Agency for Healthcare Research and Quality is the sponsor. And these are some of the definitions, so you can see, and it cites some of the key areas. So you can see, technique that creates situation or environment that's realistic, representation of real events, and then the purpose of it: learning, evaluating, testing, or understanding systems or human actions. And then you see some stuff from the research literature on in nursing about, again, it being a form of pedagogy, which I'm really glad to see that as well, a form of the way of teaching to promote, improve, or validate a participant's progression from novice to expert. And that's, of course, from the nursing standards and the nursing world of simulation, which that whole progression from novice to expert seems to be sort of a foundation in looking at students moving on to competency and then on into their field and maintaining their profession. And then just sort of other definitions being like a general application of simulation for implementing some type of a model. So I think we see a little bit of that in MCI. Now, in this article, they start out with a definition that they gleaned from some pre-hospital research that says techniques that imitate pre-hospital patient situations designed to demonstrate procedures, decision-making, and critical thinking. So they chose that specific definition for simulation. And then the purpose of this was to provide, and actually before I said saying that, they did reference, which I was glad when I looked at this article, the first thing I thought of was the super study. I mean, the NEMC sponsored, Kim McKenna, primary author, presented on the super study in 2015, it had to be some time ago, on the simulation use in paramedic education research. And again, a lot came out of that, a lot of thought-provoking, some not surprising, some surprising things. Simulators in boxes, the heavy emphasis on fidelity, meaning as a definition of simulation that's connected to the mannequin and whether or not they cry or do many different blink and get different realistic features of the rubber mannequin. And some of those mannequins sitting in boxes growing dust. So there was a lot that came out of that. They did reference that article in here, but what they wanted to do, so the purpose here was they wanted to provide, and this kind of got to me too, a systematic map. I'd never heard that term before, a systematic map. I've heard of a systematic review, heard of a scoping review, We've talked about research, methodologies when it comes to literature searches and evaluating the literature, doing meta-analysis versus a scoping review, that kind of thing. But I had never heard of a systematic map. They do describe it in here as a systematic map being a literature review that maps out and categorizes existing literature, which sounds like qualitative research, to identify gaps. So the purpose sounds just like a lit review. I mean, that's what you do a lit review for, is to identify gaps for your background when you're going to take the next step in research. But I want to bring Dave in here for this because, this is a research podcast. And so we usually do kind of take a methodological piece of this. Can you help me understand a systematic map versus a scoping review versus a systematic review, meta-analysis, these different types of things? And why would I choose, if my purpose is to look at the state of simulation in pre-hospital care as a, in the literature, in the research literature, why would I choose a systematic map versus other things?
And to be quite honest with you, I had to look this up. There's a bit of the article that this and we're always trying to be complimentary to people who do research, and I'm glad that Adam Diamond here, he's a paramedic, he's potentially a PhD candidate and has a grad diploma. I think you always look at the source, and this is Charles Sturt University. I'm so glad that they contributed this. The journal is the Australasian Journal of Paramedicine, which is widely available, open source. It's climbing in notoriety and tier in its tiers, and so it's being cited more. So all these are good things, but when you start looking at they cite the article that gave them the typologies of different reviews, and there's narrative reviews, there's critical reviews, there's meta-analyses, which really are techniques to statistically combine different very large studies and then rank them, and it's a way to say, look, based on all of this one intervention or one drug, it really actually works despite the fact that it was studied in different settings. The search methodology here is what becomes critical, and that is a problem with this paper, and I will not lie, I am not a fan. So you're gonna see me be very critical, not necessarily of the format. If this review is exhaustive, scoping reviews allow you to not only they allow you to wander a bit, if you will, from something that's more like a systematic review. A systematic review forces you to rank the evidence. So if there's a paper, and there are in this particular article, there are some EMS World, sort of here's what I do in my simulation program type of articles that are not research. Then in a systematic review, they would either be ranked by level of evidence, or they wouldn't maybe even make it if that was an inclusion criteria. So you always look at what are they including in this review and what databases did they search. And these methods are really, really kind of sloppy. Why? So ERIC is an educational research database, and that's great that they searched it. Medline is widely searched and very good to do. And CINAHL is also a great resource. So they only searched 3 databases out of potentially EBSCOhost is another one that has a lot of educational research. And then they really focused on periodical work. So if you do that, you cut yourself out of things like articles or textbooks. So this is the Foundations of Education. It's an MSc textbook. And there's an article, an entire article on, an entire chapter on simulation. So in a scoping review, you would go hand search the references that are in the back of this chapter, which, it's a fairly recent text, was updated, I forget the year, but in the last few years, and it has 41 different references and another about 20 additional resources that all would point you to pre-hospital articles that are not included in the article that we're looking at. So it's an example of someone who's kind of they're by the way that you describe or your methods, you're actually creating a recipe for the next researcher to repeat your study and find the same thing. And in this particular case, the recipe is suspect. Not only because it's just 3 databases, they didn't look at books, and they arguably missed articles that are in Medline, because then the next piece is that the word EMS, emergency medical services, EMT and paramedic, these are filters, right? And pre-hospital, or the terms for pre-hospital, are so varied in so many different countries that you could have a Brazilian study where nurses are the primary pre-hospital provider, and it might appear like it's a nursing study at the onset, but they're talking about pre-hospital work. So there is a filter that Burgess developed initially and has been since refined, that is a pre-hospital search filter. So you can go into Medline and apply this search filter to any articles, and you'll do much better at finding the stuff that's actually EMS related and not just emergency medicine as in hospital. The other methodological faux pas here is that with inclusion and exclusion criteria, you would need to say, we are really going to look at simulation or simulation of this type, etc. And in this case, they include articles that have nothing to do with simulation. So the Kylie Dyson article, which is beautiful and very important about how little cardiac arrest exposure we have in the field, is not about simulation. It's about cardiac arrest in the field and the fact that, students and providers don't get to do a lot of it, which is great. It should probably be in the introduction as a reference to, hey, we don't get to see some of this stuff very often, so simulating it is a really good thing. But when it's in the back part of this, you sort of gets, it gets a little messy, and they missed important papers. Dr. Sturt did a great study in Pittsburgh comparing intubation with mannequins versus field intubations in real patients. And they here they did a nice job of talking about the other simulation study Tavares did, and Dr. Tavares, Walter Tavares, is in Canada. It's a great researcher comparing OR success rates if you had mannequin or previous OR. So that's really good. It really gets us down to the brass tacks of what we want to review. And yet, there's work around pre-hospital airway that was really important that's in Medline, and somehow it doesn't get in here. Another step that is potentially really worth your time and energy when you're doing a review is to send it to a group of experts. So so that you have sort of at least the people who wrote some of these articles may actually know a lot about simulation. And there's a beautiful article. It's a short little piece in GEMS that Amar Patel and Jennifer McCarthy and Andrew Spain did, who are really prolific in all their work with the Society for Healthcare Simulation Healthcare group, IMSH, offers a certification on how to be a simulation instructor or specialist. And they or work kind of classifying that. So you would want to just send it over to Dr. Patel or to Jennifer or Andrew and say, this is what I've got. Do you have other articles that pertain? So it's very suspect when you only come up with 264 articles total, which is what they did. And that that would indicate that there's probably thousands of articles on simulation initially. So it's messy that they report the total number in the methods. That's usually in the results. So there's a bit of reporting and editorial work which might have been caught in the Australasian Journal of Paramedicine before they made it to publication, that are perhaps, you know, some stylistic issues, but definitely some referencing. And I'll, you know, defer to you to start talking about the results.
Well, actually, before we do, I do want to tease out a couple of questions that I have about what you're talking about. Because again, I'm trying to think as a novice researcher, if I want to do this, where did things go wrong here? And do you think using the terms "and education," do you think that narrowed it too much and that missed all those studies you're talking about? We're comparing the OR and the mannequin. They may not have used. And how valuable is it? Like if I'm going to the gray literature, as they call it, in a scoping review, like I'm looking at a book chapter and I'm going to references in the back, how valuable is it and what can I learn from looking at the search terms at the bottom of the articles? You know how you pull a research article and it says, these are the terms, to pick up patterns of which terms should I use? Do we have a guide for a researcher doing a systematic review or, you know, on something like this to say, these are the terms you should try, and if that doesn't work, these are the terms you should try, beyond just sending it to other people?
Brett Williams did a nice article on kind of assessing scoping review reporting and methodology. It's also in the Australasian Journal of Paramedicine, and it is a free article, but you can get it even if you're not a member of the Australasian. And so reporting these things, there's structures called, and in fact, SJR here is mentioned in their explanation following the reporting of certain types of reviews. So it is very helpful to look at how those things are structured and follow the recommendations of Joanna Biggs, I'm butchering that. It's the Prisma SCR format. So novice folks, you know, could look at that, and when you look at a normal search, you're looking at Embase, Medline, ProQuest, MCare, and all evidence-based methods, including Google Scholar, so that you're searching 6 electronic databases, and then depending on how you set up the search in either Medline or EBSCO or some of the tools that you might have available to do this, you have to set your and or switches so that you can, you know, get you sort of cast a wide net, and then once you have a wide net, you come back with, you know, sometimes thousands. In my scoping review, one of the scoping reviews was like 6,000, 8,000 eventually, and then you put them into sometimes a very useful piece of software that will allow multiple reviewers to go in and say, let's do a title and abstract search, or, you know, identify out of these 6,000 which ones are pre-hospital, and that's like just people looking, and if you have 2 reviewers and there's concurrence, then you've got, okay, that one is included. We're going to put that in.
Yeah, and then there must be patterns, the key terms after a while. But you know, as we see, sometimes it's pre-hospital, sometimes EMS, emergency medical services, you know, paramed with an asterisk or whatever, so that you have
the filter.
you get a wide net. Yeah, the filter.
You do much better because somebody already validated that filter. Otherwise, you're just sort of it's a kind of haphazard, and it's kind of amateur night at the Apollo if you're just gonna. It's like going to Google and typing in paramedic simulation or EMS simulation. You'll get stuff, but how much of it, you know, how are you really capturing what you need to do? That's why they call it systematic, because you report the way you did it, and that's a systematic review. And it's a method, and you should be able to repeat it and get the same result if somebody else would. I mean, if you think about science and research, that's the whole point of it. You've got to be able to make it reproducible. And I think that's a problem, because if you can't, if you don't report your methods right, or if your methods are pretty partial, it makes the strength of the study very, very poor.
I like the way a review also has that chart, or that flow chart, that starts with the large number and then whittles it down and shows you the inclusion and excluded for this reason, included for this reason. And that way, actually, even just listing the inclusion and exclusion criteria, then having a chart that shows why certain ones were excluded. I find that very helpful. And I don't know if that is, an international, trend that you see across, some things I'm not sure if there's differences in different countries to presenting research, or if that's just, it seems it's very pleasing to the eye, and it's very easy to look at, something that's visual like that, a visual representation of the way they've selected. So that was one thing that I thought, where is it? I was looking kind of for it, and then I thought maybe the systematic map is something different. So.
Yeah, I love it, and thank you to Rebecca Rigney. I hope I'm saying that word right, Rigney, that shared the Brett Williams systematic review of scoping reviews, and the link is in the Q&A. So that's helpful too. I think that one of the things they could have done is limited. When you look at the Patel article in GEMS, they really divide simulation into kind of 4 groups. It's teaching and education, so simulation to teach, simulation that assesses and evaluates a candidate's ability, right? So and then you have system improvement kind of simulation, like we need to make sure that people know how to do this that are already working. And finally, simulation that is trying to research something, like intended for the purpose of answering a research question. So I like those 4 categories that they use to, and this group could have divided the science that they found into these categories. The style of lit review that they're doing is sort of like I said, it's almost like a narrative review. They didn't include a table, which is very normal for people that are doing a lit review, is to just include the table. And you actually see that in the article that they cited on the types of reviews. That's also a review article, and they show you a table of what each one is.
I have one last question on that, and then I'd like to bring Katie in. Katie's O'Connor is joining us. Bilton's out there too. I can see he said hello in the question area, so if we can bring him in as
well.
I'm there he is.
I'm here. Don't worry, I'm listening to Dave. I'll sync him later.
Okay. I do have a question though. Sometimes you mentioned ProQuest. So dissertations come up. Where do dissertations fall in any of these reviews, if at all? Because they're not really.
Yeah, good. That's a really important thing. So they found it. I think they found a dissertation, but there's definitely dissertations about simulation, and sometimes
more.
Are not. Those are never published in a peer-reviewed journal. They're not. It's hard to find them. There are usually the university will do a repository. It used to be like physical, and now it's digital. And there are national and international repositories of dissertations. I'm shamefully, I can't remember it off the top of my head. Maybe somebody listening will join us in the Q&A there. I understand the chat is only visible to the organizers, but feel free. So in modern day, there's a spot where you can find people's, graduate dissertations, whether they're master's, PhDs, EDDs, etc. So I will find it and share it.
Great, thank you.
I actually have a question too about abstracts. Just because I'm thinking of all of the PCRF abstracts about simulation that were just showed at EMS World. And of course, they didn't show up anywhere here. So I didn't know if abstracts could be included in this lit review.
Oh, that's a really good point. That
Mhm.
is the bane of my existence. So
Yes.
PCRF is great about abstracts and getting those out. And you can go actually onto the PCRF site and search every abstract we've ever done since 1992. The thing is that abstracts are like the trailer to a movie, and if you never write the paper, you have like the commercial for the movie, but the movie never finished.
Mhm.
You know, Alec Baldwin just probably accidentally killed a producer on, you know, this news was breaking.
Yeah.
Who knows if that movie ever actually makes it to the screen, right?
Yeah.
So if you have the trailer and you have like the commercial for it, you've probably already done the research. You know, obviously all the PCRF stuff, the research has been finished. Otherwise, they couldn't produce the abstracts and get them peer reviewed, and they've already been IRB approved. So all the work is already done. You just need to write it up. And I am the worst at this because you got to finish the stupid paper and get it
I'm the second
published.
worst. Yeah.
And I love the research process. I love what it teaches us. And then the stupid paperwork at the end that isn't so stupid, because that's how people actually get the stuff that you did.
Mhm.
Unfortunately, if it doesn't happen, it doesn't happen. Now, there are publications, to Katie's point, where you can actually cite an abstract. You would cite it as a paper presented at a conference. All right. So conference proceedings are in some repositories. And if you chose a scoping methodology, you could say, we also included peer-reviewed, you know, or not peer-reviewed if you wanted to, but you know, invited speaker or peer-reviewed abstract publications that are part of a conference. So IMSH has a ton of invited speakers on simulation that I am sure have done great work. And if they happen to have somehow published those either the abstract of what they were presenting or some form of it, you could cite it as a potential source, depending on your inclusion criteria from the beginning. If you say
Mhm.
we only wanted empirical research, or we only wanted, you know, research that was this type of study, then you can discount everything else. And if you're doing a study about a meta-analysis of amiodarone, you're not going to go with, you know, an abstract that somebody presented as an invited speaker. You're going to go with randomized controlled double-blind trials, or something that, you know, where you can actually combine and say these are what we think tell a story. So that's how that piece gets done.
And that comes up a little bit, and I'm so glad, Katie, you could join us too, because you have that practical day-to-day experience using simulation for a number of reasons. So just going through what the authors discovered, and then let's dig into some of this. They looked at, as David had mentioned, 264 references from the period of 1988 to 2020, used the search terms that we found to be, you know, a little bit problematic in the areas. Found 25 relevant papers and then 4 themes associated with that. That's not a lot of papers, as we said, but just diving into what they found from what they actually looked at. The 4 themes that are identified are listed up here. If you're looking at the screen, or if you can see the slides, they're listed here. And these themes were simulation literature, specific and creative. And in that area, they talk a lot more about how people would present, you know, on their simulation center. You know, we have a great center and a physical setup of simulations that involve, you know, a mock nursing home, and it was more about the technical aspects, or setting it up and how to do that. And then, you know, active learning, virtual methods, all kinds of things like that. Let's see. Oh, there was one area that we highlighted in there that I want to dig into it, but the other themes are shown here as well, which is simulation for assessment, meaning for testing, basically, simulation for teaching and learning. And then the final theme was that the simulation efficacy of simulation learning, research on that is sparse in the pre-hospital area in their search. So that was what they concluded from the stuff that they looked at. These were the 4 themes. Now, what I want to bring you in on is, and I know David mentioned it a little bit, but the 6 studies in the first theme that, literature is specific and creative. They state that the 6 studies that they looked at, there was no comprehensive method or best practice guidelines that educators can use to set up and run effective simulation for learning in pre-hospital care or in paramedicine. And David showed like several methods. So what I want to know is, you practically do this. What did you use as a guide, or what do you use to teach your other educators in there about how to use simulation without making up the latest call they had last night and running it?
Exactly. Meg, I feel like this article is the pitfalls of what EMS educators think. Like, these are the myths we need to bust, as what they highlighted. But there are standards, and I was lucky this year to help review the INASCL standards. So I think the word nursing throws paramedics off, but they're the international standards for simulation, and they're actually developed by nurses, but now it's a multi-spectrum, lots of different people. I was the representative from the National Association of EMS Educators that got to review some of the new standards. So there's a lot of paramedics there, and we have a whole EMS affinity group in the Society for Simulation Healthcare.
Yes.
So there's definitely standards. They're really well done, and they're from not just paramedics, but nurses and physicians and allied health professionals. So if we're talking about the best things for anesthesia, airway management, maybe we should be looking at anesthesia guidelines. We in paramedicine do a whole bunch of different things. And so, yeah, for sure there's that. Dave mentioned there's a whole chapter in the NIMSI book. Society for Simulation Healthcare has a whole bunch of great resources on it as well. The affinity group is free. You don't even have to be a member. There's all of these resources out there for best practices. And I mean, COE even has some too. They're a little bit more vague, but there's something there, right?
Yeah, and that for the last couple of months, we've had the National Registry on with us, because they're both pieces of education research that we looked at for the last few months related to the research priorities, I think was the last one we looked at. And, we talked simulation, just has to come into those conversations because of the, student minimum competency with the COE and the documentation of progression of learning and what we're learning from the, other research. And then the whole discussion about the changing and evolving test. And if you haven't heard this about the National Registry and the change in the psychomotor, the sunsetting out of the psychomotor exam at the advanced level and the replacement with something critical thinking, simulation based, you better go to the website, to the National Registry website, and look at it. You probably got an email like most program directors did, and maybe instructors and clinical coordinators did. I'm not sure how wide that went out, but that this is coming. And so check it out and look at that, because this directly, simulation directly relates to this, and standards, and how to then carry that out to your educators and follow and use a standardized practice is really important. Wouldn't you agree?
Yeah, and you know what? I think Katie hit the nail on the head when she said this is like all the worst stereotypes you can have, all rolled into one apparent review article that would think. But they in the article they say, well, there's nothing out there that says simulation actually works or how it works. And that is completely false. There's just a ton of evidence that involving students in simulation is it helps retention, it helps critical thinking, and it's true. We need to do more in EMS education to show that to prove that paramedic simulation has the same effect as it does in other areas of healthcare. But some of those are not far leaps, especially when you think about, the kinds of populations that those studies had, where, you're talking about, folks working in emergency settings, whether it's emergency department, nursing, or physician. These are well accepted practices and great studies to at least say there's lots of evidence that really this really helps. And that means that if you're a budding researcher and you want to really actually make an impact, you just follow the recipe, follow the methods of one of those nursing and physician studies in emergency medicine, and repeat it with a pre-hospital flavor, so that you can show not only does it improve critical thinking or ability or reduce errors, improve retention, these things also can be done with, pre-hospital simulation or simulation about regarding pre-hospital. Not just paramedic, EMT as well. I think
there's a lot of great data on MCI from like EMS. So that this study missed in some of their lit review, we talked about why, but there's been a bunch of MCI driven ones. And in fact, there's even a virtual simulation that's been proven to be effective in increasing MCI and triage of like knowledge of the pre-hospital providers. So there's just a ton out there.
There's something in here too that I want to tease out, and that is because I don't want to make it sound like, well, there's so much stuff out there, we already know how to do it, because we still have issues, lots and lots of issues with, walking in and saying, well, I'm just going to use this call that we had, I'm just going to use this on this, and not taking the time to actually attach it to educational objectives, to blueprint like you do an exam. Like any other testing, right? You have a cognitive exam, you're going to blueprint it, you're going to, attach it, and you're going to go through the item analysis and everything else. Simulation should have the same thing. It's constantly evolving, right? What aspects of the simulation itself. There's also terms that I think that we need to clarify in the healthcare. So, and I will, I don't know if it's a conflict. It's nothing financial, but I'm also a member of the Society for Simulation in Healthcare, and just became one not too long ago. And the EMS Affinity Group, all of like our people, right? It's so great. So, think about something like that. And the cheesy certification is next, which is the, certification as a healthcare simulation educator. So all of these things are out there. And I think EMS we just need to bring more of you all wonderful educators out there to the table. And then we need to be educator researchers too. But getting to the terms, so we use the term skills, we use the term scenarios, we use the term simulations. And when they talked about using simulation for teaching and learning, they talked about largely what they saw was the teaching of skills within simulation. And which I thought was interesting, because you do see critical thinking points, and again, they missed a lot of the literature, I think. But there's the scenario itself, which is, the specific thing that surrounds the story, basically, and then there's the simulation, which is the realistic, the imitating life, a real life scenario. But the scenario itself, we use these terms, skills, scenario, simulation, and we tend to think of Dennis Edgerly, I think, had this fabulous presentation years ago at NEMC that I'll never forget. It was a really good one, and he was very practical, the practical aspects of bringing out, a good simulation, and gave us some great ideas. I would literally walked home and got my toolkit out that he gave us. But he actually talked about, the skills themselves, and then the scenario being more targeted, like an ACLS scenario, a mega code, that being a scenario, and then the simulation being, putting it in with all of the other elements, the affective elements, the other things that are, and the, safety elements and the distractors and the bystanders and things like that. Then there's levels of simulation too. So some students aren't ready for the, simulation where you have a lot of safety issues involved, in addition to doing, running a cardiac arrest and performing, complex skills and things like that. So it's, there's a lot there to tease out.
I know, and part of it in this paper, they talk about how so many of the things they found were really focused on one aspect of simulation, which is just missing it. And I think a lot of times in EMS, we get really focused on the level of fidelity of a mannequin. I mean, look, we're in California. We had this discussion during COVID. California literally defines fidelity as the number of pulse points on a mannequin. Virginia does the same thing. And I'm like, dude, a human is going to do a way better job, simulating effective domain than a mannequin, right? Like, if I'm wanting to do a sim around the big topic that's talking now is death notifications and resiliency for paramedics and EMTs. And, we're, because of COVID, doing so many more death notifications and end of life discussions that's not really anywhere in our, it's not on the student matrix for COA, right? We don't have to check box it for COA for paramedics. So are we doing it? We don't know. We're not collecting data on it. And that sim, I would definitely want to do with a person, not with a mannequin. Like telling a plastic mannequin that his plastic babies have died is not going to be the same level of fidelity.
We agree that there are critical procedures that need to be done on mannequins or task trainers that allow us to do an intubation, because that's really hard to be doing on a human. But I think wearables and devices that allow us to, like the iSimulate tool, allow us to actually put a 12 lead EKG on a real human and know that the leads are in the right spot is referenced in this article as, they wanted to create a mannequin to do that. And I'm like, that is so last century. Like, we cannot be thinking that we make the plastic more human. What we need to do is let humans play the part of a human, and the students learn from actually being the patient that they're simulating. Not only do they learn the symptomology. What's that?
Humans aren't just men. They're talking about how to make a male simulator for 12 lead more realistic without even talking about breast tissue, which is a huge problem. Like, huge.
Yeah.
Like, absolutely.
Speaking of humans, can we bring in Bill here, because he has played a patient for you, Katie. He is human.
Bill is very good fidelity.
Human. He goes to the gym. Where is Bill? Bill, are you there? Can we make fun of you? Come on.
Oh, you certainly can make fun of me, and it's more fun to make fun of me when I can't respond.
Exactly, and we can't see you either. So, Bill, can you talk to us a little bit about, and I know you've done this already on this podcast, but I want to hear about you playing the patient in the virtual simulation that had to happen because of COVID, which we actually have to talk about too, but, what's happened as a result of COVID. But, what kind of things you're hearing us talk about, what the student can learn, and what did you learn out of what you could do as an educator in simulation by playing the patient?
One step before we go to that, and I will answer that, I do think there needs to be standardization of the terminology, nomenclature, however you want, because there are so many different things that are used that quote is simulation that we don't know. So I really think there needs to be an effort to really standardize that terminology and stuff. I think would help immensely. But I have, particularly with the advancements of, and this is not to promote one product or not, but one of the beautiful things I liked about the iSimulate when I first saw it is it finally meant I could use a human, a real person, to play roles with some minimum moulage, but they actually could put the blood pressure cuff on, and it would give the automatic reading, would give hypertension or shock or something like that. And then, but the key that you get is if you have someone who really knows patients, the model, that really understands what it's like to be a patient and the different signs and symptoms and presentation, they can very well create that environment for the student to really have to be able to collect a good history and really do a physical exam. And I think that's the power of using a real person versus these very high fidelity simulation mannequins. Now, VR may change that in the future. That still has an area of great promise. But I do like with what we did when we did it with the UCLA program, is it really gave the students, it was less about the treatment and it was more about them collecting a history from me and talking to a difficult patient. And then talking to also someone that looked the role. It was easy for me to be a 60-year-old male with respiratory distress or chest pain because I am 60. So I look
scenarios.
Huh?
I cherry picked your scenarios. I gave you ones that were really true to your core character.
Yeah, but also to, who I am. We've always joked. I always thought it was funny when we throw the guy down there that's 40 and say they're an 18-year-old pregnant girl.
Yeah.
Yeah, and I think there's something that's distracted from that. But the key thing is that if you have a well programmed model, they can really and I still think when I watch EMS providers interact with patients, it's painful because I just don't see them really having a very casual flow, collecting information and getting the story from the patient. And that's the skill that really, to me, it's the crux of, patient assessment, is being able to collect that comprehensive history and to constantly go back to it and understand how to tease and probe it out. And, I think that
on the check sheet, though, Bill.
Pardon?
Only 1 point on the check sheet.
Yeah, exactly.
Which is crazy, but that's a separate story.
That should change. High fidelity became synonymous with fancy electronic mannequins, and if you look at, couldn't agree with you more, the dictionary, you think about fidelity. I'm actually reading the words here: fidelity and fiction contract. Making sure that you have the right contract with the students to say, we're going to suspend disbelief. We really have to agree that we're going to try and make this as real as possible. And then really differentiate between standardized patients, which is again, these terms have been defined. And what we need is educators to just learn those terms so we can talk apples to apples.
Yeah.
One, you mentioned VR, and I, if you're a paramedic program or EMT program that wants to participate in a study, there's a group getting formed to actually try and see that and see if in fact VR can be used. We tend to, and a shout out to one of the sponsor of this podcast, which is FISDAP, that these groups of schools that track data need to really actually look at it in a scientific way, so that we don't just throw out requirements of iterations of things without knowing if it really matters to education and what the effect of these interventions are. And it's dose dependent. It's not just that you do it one time, it's how often and what kind of thing are you going to do, so that the concentration, it's the 5 R's of simulation: the right dose, the right patient, the right, honestly, and the right checklists, because all of that is based on evidence. Really matters.
A word about checklists too. I think required reading should be the checklist Manifesto by Atul Gawande, so people understand that checklists are not all, check and do. They're sometimes confirmed checklists. Sometimes they're ever evolving. They're not. It's not a static thing. Thou shalt check this. Thou shalt.
And that was actually, not to get off topic from this article that we kind of wandered away from, but that's in the article that in fact checklists were useful, and they reference the use of checklists, but they reference them for like setup of things. And sure, you can have a list of stuff that you need for the simulation, but doing aviation style stop and verify type of checklists that are, essential in a crisis situation, it is really the way to go in the future. I can't tell you how upset I am about trying to read our protocols. They're paragraphs full of if, then, when, this, that thing, and then the again, and you're like, it's trying to teach you stuff at the same time as it's trying to give you the dosage, trying to tell you that won't work with this. It's like, OMG, I need to be able to pull it out in a crisis and go, this is what I need to do. And the more we do that, the more we'll have better criteria to evaluate and assess whether learners are doing the right things in their simulations. Otherwise, we all have different scales. We all have different types and depths of fidelity for our simulations, and we're not measuring apples to apples. We don't really know what we're doing.
I also just want to highlight some of the things that they said in this article was that prior experience in simulation gives better, you get better performance in simulation. So we know that once you try something, you do better the next time, right? The same thing's true about simulation in the checklist. And conflicted here, I'm like the president of the iSimulate fan club, like Bill is. But we did the simulation scenario challenge, and like the iSimulate scenario challenge is all about what we're talking about, assessment, fidelity, and like actual patient interaction. But you look at something like the GEMS challenge where it's very different, right? So we're doing 2 different types of simulation with 2 different check marks and criteria. And so if you're practicing for one that's all about verbalization, and I call it jazz hands, like Scene Safe BSI, versus one that's actually making you look and see the scene and respond to the hazards, you're going to perform differently. And so when we look at how are we doing this in paramedic or EMT education, and then how are we testing it? Are we testing like integrated out of hospital with you have to actually interact, and then they go to the next room and they test trauma assessment and you have to verbalize? Like those are two completely different skills, two completely different ways of testing and assessment. You can do both, that's fine. I mean, I have some opinions about why you shouldn't do one, but that's really important. So when we think of all of these things as like the same, like the sim, it's not the same, and you're not going to get the same performance. And a static, isolated, I went through one scenario one time is just one data point that doesn't really tell you much, which is why it's like so great that the registry is taking this kind of testing off of the table, because we just know it's not great, and that the more that they do it, the better they'll get.
It also starts in EMT, that whole third person narrative. They're narrating as though they're watching themselves do something. That, I don't know about you, but it drives me crazy, you know, when people say, I'm doing this and I'm doing that. No, you're not doing it. Do it. I don't want to hear it. Do it. And you can talk and do, right? Talk and do.
You're getting, you guys are getting back to something I've talked about and I talk about a lot of time, is we do not have instructors, educators, whatever title we want to use them, that have developed this skill. We have a tendency, this is the way I learned I was taught by my most favorite paramedic instructor this way, so this must be the right way to teach it. And we continue to fall back on that. And so we still see, I can't tell you how many times I see pictures and equipment is up on tables and they're just, you know, they're doing things where patients aren't. Why aren't they on the couch or sitting on the cot or on the floor? Why is everything always on a table? You know, that's not the way we do things. And if you're going to continue to do that, we can't even get into some of the advanced things that we want to think about as it relates to critical thinking, because I think we need to help improve the educator to be able to be a better educator. And then as well as lab instructors, and the list goes on about who needs to know more, because otherwise we will just continue to perpetuate what we've always done.
Yeah, and that continues in the field with field educators, right? We have to sort of sell the value of simulation to everyone, not just our own lab instructors, because the students are going to go out on their internship, and the value of them returning to do simulation to confirm that they can perform that cardiac arrest can, you know, supersede that whole, well, we haven't gotten a critical patient, so they need to stay 500 hours longer. No, we actually have.
And I'm going to lecture for another, you know, I'm going to lecture again on the same topic you already know about, when in fact what I need is I haven't seen a pediatric arrest in a year and a half. I need to actually simulate the pediatric arrest. And Bill can speak to this at Johnson County MedAct, where, you know, the battalion, the battalion chief, the BC, that's the educator who has a rank enough to actually intervene and pull you off the street if you don't know what you're doing, is driving around with a mannequin going, hey, either rotate the crews through here, or I'm going to go find you. I need to see you do the cardiac arrest to the standards that we want, to whatever it is. No pauses, compression depth, make sure that the automatic CPR device is on, you know, with the right speed, or the intubation's in the right time, that you're actually drawing up the right medication, that you know which one it is. And these things aren't lectures. They're, let's work as a team, and let's get that in a system where the first responders are involved and participating, so we get the multidisciplinary team approach to simulation. That's really the future of education. And this you know, unfortunately, virtual Zoom lecture of, you know, it doesn't work. It's not going to get us the critical thinking that we need. So
the one thing they didn't mention in here too. Yeah, well, I'm sorry, say that again.
We're talking about it, right? Like the phrase we're talking about right now is transfer to practice. And are we doing things in EMS education and simulation that actually transfer to practice?
Yeah, and that requires research, right? And that addresses, here goes the call to arms. One of the things I didn't really address in here too is something that's coming up for everybody, which is, replace versus enhance versus both. Can simulation replace certain things that we traditionally, are we going to wait, 17 hours for a delivery, or are we going to say, okay, we've tried, this many shifts and this many whatevers, and now we're going to have to do a neonatal resuscitation on X number of, patients or whatever. And some of that will require research. So we're going to have to fill that gap to help, if it exists, to say that this can actually replace it. But then we need that transfer to practice as well, if we can get it. But the replace versus enhance. So I don't think it's mutually exclusive that we're saying simulation should replace certain things. It might actually enhance. So the virtual sim is a great enhancement, I think, for critical thinking. Get individualized learning in there. You can hit somebody on Zoom, a small team on Zoom, a lot easier than you can make people wait in the hall with a small team in your simulation lab. If you're getting at if the goal is critical thinking, you can get that decision making in a virtual simulation. But if your goal, has elements of procedural skill to it in the setting of a chaos, then, a face-to-face simulation might be better. I mean, all of those things have to be discussed. And then we have all kinds of listservs, right? Katie, you and I are on a California one. There's the national one that Jeff Anderson, I think, started. And there are all kinds of great discussions out there in those. There was a recent one on the use of what's the best? Anybody have any experience with a stethoscope, with a simulation stethoscope? So I don't have to play sounds on my iPhone or tell them there's wheezing, and so we talked about different models of stethoscopes out there. So we're a team out there. I don't want to harp too much on that, but it's nice to be. It would be nice if we became a team of educated researchers as well. So we are at the top of the hour. Yeah, we are at the top of the hour, and unfortunately, we always have the best discussions right at the end. But I want to thank everyone for joining us, and let's keep this discussion going. I did have one slide that I can skip over that showed their cardiac arrest data from a system to explain that they could define rare events and use simulation for rare events. But thank you everyone for joining us. Now I will tell you, we're going to be passing 2 months again this year because our fourth Fridays fall within the holidays over Thanksgiving and then over the winter in December over holiday season. So what we're going to be doing is seeing you again in January for this education research podcast on January 28th, 10 a.m. Pacific, noon Central. But we have the clinical podcast still. Monday, November 8th is the next clinical podcast, again, 10 a.m. Pacific, noon Central, and the International Research Conference. Don't forget about that.
Educational research too. Yay!
Yes, with lots of educational research. Please check that out and let's join us in further discussion. Thank you, David Page, Katie, Bill, for joining us. Thank you all, and we will see you soon. Email David Page if you have an upcoming article, dpage@emsed.net. Thank you all.